So questions about the test. As of right now, the plan is it's going to go through diabetes. I think on the study guide that I posted for you guys, there's also on the study guide research methods stuff. That's not going to be on there. We're going to cut off today, okay? So it's just going to be diabetes. It's going to be the endpoint. I'm going to post it right now unless you tell me otherwise, and a couple of you guys have reached out that we're going to do it at 10:30 and you're going to have until 2:30 to get it turned in, okay? If you have problems with that time frame, I need you to email me today, like as soon, like right now while we're in class or when class is over, so that I can set it up correctly, because I've got one person or two people that want to take it this evening, so I want to go ahead and get that set up for them. I got to do it all at once, okay? So if you need a different time, let me know, okay? Format just like last time. There'll be an Excel sheet, and then there'll be that you will send to me an email, and then the short answer stuff you'll do on a Word document, and then you will send that to me. The bonus will be the same as last time, okay? Bonus will be the same thing as last time. Some clarification on all of that. When I say tell me things that you learned that we didn't ask you a question about, did you guys like that as a bonus? Just I'm curious. I always would get mad as a student when I would study for a bunch of things and then they wouldn't be able to ask a question about everything. I'm like, I know so much more than what you asked me. This is bullshit. And so I try to do bonus that way, right? I need you to be specific. I need you to say, right, not just, I learned that ice is not effective at, right, as a treatment for soreness. What I want you to say, much more so is like things about what we covered in class, like, right, like that I learned that heart rate is regulated by both the sympathetic and the parasympathetic nervous system via norepinephrine, epinephrine, and acetylcholine. I need you to be very specific. You can't just say like, I learned about heart rate regulation, or I learned about the FIT principle. You got to tell me something much more specific, a specific fact about those kinds of things, okay?
I have a question on that.
Yes, Madison.
Would bro science questions also be like okay in that?
Sure, that's fine. But you just need to be, you can't be like, yes, I learned about the use of ice on those things. Like, I need you to say something a little bit more specific than that, okay? So yes, people have tried to be really cheeky and say things like, I learned that Dr. Black's dogs are basset hounds, or that his daughter's name is Ellis, or if she's done something and we've talked about it, they'll say things like that. And I appreciate that you guys pay attention to those things and that's the stuff that you remember, but I would really like to try to limit it to things that are kind of within the scope of class, okay? But yes, bro science is fine. It's fine, okay? All right. There seems to be, was there anybody, I had a couple of people that said they had problems getting the lab turned in last night on things and ended up emailing it to me. That's fine. The timing on all of that seemed a little strange, but I assumed the most of the rest of you didn't have any trouble getting with the Dropbox or anything. Okay. That's fine. All right, so we're going to talk about diabetes today. And there's going to be a lot of stuff in the PowerPoint on kind of the back third of the PowerPoint that we just don't really have time to go into all of the depth that is there. We have a little bit more time in the regular semester, but also diabetes is Dr. Pinku's baby because he's a type 1 diabetic. And he does research on these things. And so the lectures that we've put together, he kind of put most of this one together, and he likes to go into a lot more depth because he's really passionate about it, a little bit more so than I do. So you guys are going to see some stuff towards the end, and I'm just going to say like, ignore that slide, ignore that slide, ignore that slide. Here's the big take home from this particular slide. Okay, he's got a lot of kind of data and things from various studies, and I'm just going to kind of hit the high points on all of that. So, but I'll try to make sure that I'm very specific when I point out what I do want you to know on those things, okay? So nobody freak out when I'm like, yeah, don't worry about that, don't worry about that, don't worry about that. Okay, so let me start off here. We've got this up. And so let's start class this way. How many of you know somebody that's a diabetic? to be type 1. What is happening? Here we go. How many of you know a person that's diabetic? Type 1, type 2, doesn't matter. Okay? So many of you, it looks like, know somebody. Okay? Good. So that, I think, is going to be really, really important. We're going to talk about the two different kinds of diabetes, type 1 and type 2. How many of you, the people that you know a type 1 diabetic? Okay. Several of you know type 1. How many of you know a type 2 diabetic? Okay, many of the same of you. Okay. So we're going to talk about the differences between those, and we're going to talk about that really it's going to be type 2 diabetes. And so those of you that know somebody that's a type 2 diabetic, we will talk about how exercise and maybe some diet modifications can have really, really kind of profound beneficial effects on them. And then we'll talk about why, if you're a type 1 diabetic, you've got to be really, really careful about exercising. John.
Are these slides posted on Canvas?
I thought that they were. From your question, I'm going to get the answer that y'all are gonna say they're not. So let me check. I'm looking. Nope, of course they're not. Okay, they're now published. Sorry. I'm now putting up the next couple as well, just so that I don't forget. Okay, they're up. My apologies. Right. Okay. Back to this. Alrighty. So what we're gonna go through is kind of what are the dangers of being a type 1 diabetic when you want to exercise, because while it's very, very beneficial to type 2s, it is potentially beneficial for type 1s, but then because of the nature of the pathology that they have, it can also be really, really dangerous. Okay. So how many of you guys have had a bad internship or a bad experience where you had to you were the low person on the totem pole somewhere, where you're like, man, my internship sucks, I get the crappy jobs? Anybody? Okay, a couple of you guys, maybe. All right, well, think about whatever it was that you had to do, or what you could think, like if you had to go work in a hospital or something, and what you think the worst job was. And I promise you, it's not as bad as what it could have been if you were in the medical profession 100 or 200 years ago, okay? So diabetes is a couple of different disorders that have different pathologies, but kind of the same endpoint. And we have named it such. It's a metabolic disorder where you're going to have difficulties with glucose metabolism, getting glucose from the blood, from things that you've eaten into your cells, okay? And the reason why that happens is going to be a little bit different. But it's called diabetes, which is from Greek and Latin. Diabetes from Greek is to pass through or to siphon, okay? And then mellitus, so the official disorder is called diabetes mellitus. Mellitus means sweet or honey-like. And it got this name because way back in the day, okay, the main method for diagnosing somebody as being diabetic was you had to inspect, and by inspect, what they really mean is drink the urine and detect whether it had a sweet taste and fragrance to everything, okay? So whatever you thought you had to do in your internship that sucked, at least you weren't the person drinking urine to try to figure out if someone was diabetic or not, okay? So life could always be worse in some ways. And so why do you guys think that urine would be sweet, or kind of have a sweet fragrance in a person that is diabetic? Anybody have any ideas? What's going on with that? What's causing that?
If cells aren't taking up glucose from the blood, then it's going to have to get filtered out by the kidneys into urine.
Exactly right, Emily. Exactly right. Okay. So if you need to lower your blood glucose levels no matter what happens. So you eat something, your blood glucose levels go up. We need a way to get that lower. Okay. Typically, the ideal way is to have that go into tissues like skeletal muscle, so that we can lower it that way and use it for fuel. But in the absence of that happening, we will just filter out some of the glucose at your kidneys in an effort to lower it down. So therefore, it ends up in your urine. Your urine has these high glucose concentrations, and that can be bad. Nowadays, we can just get a urine sample and stick a little strip in the urine sample, and it will tell us if you have, kind of what your rough or approximate glucose levels in the urine are going to be. Okay. So in the present, okay, diabetes is, we now know, as I said, it's a metabolic condition, and you have an inability to maintain especially carbohydrate and to some extent lipid homeostasis, and it's due to either disturbances in the way the hormone insulin is going to function, okay? And that leads to impaired glucose and fat metabolism. But we're going to focus mostly not on the lipid or fat metabolism consequences of being diabetic. We're going to focus mostly on the glucose metabolism sides of things, okay? So the major symptom, the way we check for diabetes now, is not by looking in the urine for glucose levels. We're going to look in the blood. And so the primary symptom of a person that is either type 1 or type 2 diabetic is they're going to have elevated or increased blood glucose levels, okay? And you would stick your finger, get a little blood sample, put it on there, as you can see in the picture, and it will tell us roughly how many milligrams of glucose there are per deciliter that are going to be in your blood, okay? So, well, the end point is the same. If you are a type 1 or a type 2 diabetic, you tend to have elevated blood glucose levels. The end point is the same. The mechanism or the cause, how we end up at that end point, is going to differ, okay? So in the different kinds of diabetes, different things happen with insulin, okay? So if I'm a type 1 diabetic, I'm going to be what we call insulin deficient. I'm not going to make enough insulin. The beta cells in my pancreas are going to get destroyed by my immune system, and I'm no longer going to be able to produce adequate amounts, or really in some instances any insulin, to be able to signal skeletal muscle and other insulin sensitive tissues like adipose tissue and things to take glucose out of the blood. However, if I'm a type 2 diabetic, I make plenty of insulin. It's just that insulin stops working. The insulin binds to its receptors on insulin sensitive tissues, but we don't get a normal response from there. And so we call that insulin resistant. Your tissues are resistant to the effects of insulin binding to its receptors. And we'll talk a little bit about that as we go on. Okay? So here are the two primary types. As I said, type 1 is insulin deficient. We used to call type 1 diabetes juvenile onset diabetes, or something that would get abbreviated into IDDM, which is insulin dependent diabetes mellitus, okay? Insulin dependent. And so that one means that you don't make enough. It was sometimes called juvenile onset because most people that are going to be type 1 diabetics develop diabetes when they are children, or at least maybe teenagers at the latest, okay? Teenagers at the latest. And as I said, it's an autoimmune disorder where the beta cells are going to get attacked by your immune system and they're going to die, and therefore your pancreas cannot make insulin, okay? Type 2 diabetes was previously called adult onset. That has become a bit of a misnomer now because we are all overweight and sedentary. We see it sometimes in maybe not juveniles, but at least in kind of teenagers and things. And it's called non-insulin dependent diabetes mellitus, okay? Otherwise known as type 2. And so what happens is, because your tissues are resistant to insulin, then you're going to get decreased glucose uptake, and that's going to then result in an increase in lipolysis and the breakdown of fat from adipose tissue to try to use that as as an energy source. And there's a complicated interaction with all of that, because you become insulin resistant, but then you start taking up more glucose into adipose tissue, but then you start breaking down more adipose tissue to use fat as an energy source. And so there's kind of a complicated thing that's going on. Okay. which is really in some ways beyond kind of the metabolics of all that, or beyond the scope of our class. Okay, so let's talk about who is at risk of developing type 1 and type 2 diabetes. Okay, type 1 diabetics, that's immune mediated. It's mostly a genetic disorder. You are at an increased risk of becoming type 1 diabetic if you have a family member that is a type 1 diabetic. Okay, so those of you that know someone that is a type 1 diabetic, think about if they have somebody else in their family that is also a type 1 diabetic. Okay, and it's not like super genetically linked, but that's kind of the one thing that we know that's gonna go on with all of those. Type 2 diabetes, on the other hand, is much like cardiovascular disease, going to be a kind of behavior risk type of thing. And so there is certainly some genetic component. If you have a parent who is a type 2 diabetic, you're at about twice the risk of developing type 2 diabetes as a person who does not have a parent. And there's kind of a complex reason behind that. Obesity is probably the single strongest link. About 80% of people that become type 2 diabetic are overweight or obese at onset. And of those people that are overweight or obese at onset, a lot of them have a very distinct abdominal fat distribution. And so having fat in kind of over your belly button, having belly fat, that's the place. It interacts with hepatic glucose output and some things that are going on in the liver. And all of that seems to be a hallmark of the development of type 2 diabetes. We don't fully understand kind of the hows and whys of this, but it is very much a thing. Okay, so people that are overweight and obese and are storing fat in their hips or in their thighs or their butts or kind of up in their chest and things, that's still going to increase your risk, but it's not going to increase it nearly as much as people that are storing their fat kind of right around their belly button region, kind of right in that abdominal region. Okay, age is a risk factor, especially being over 45. Being sedentary is a risk factor. Having high blood pressure is a risk factor, as well as having elevated LDL cholesterol levels. Okay, so if you look at several of these things, right? Sedentary lifestyle, age, hypertension, dyslipidemia, obesity, maybe even family history, all of these things look staggeringly like our risk factors for coronary artery disease, don't they? And so because of all of that, there's a thing that's called metabolic syndrome, or sometimes called metabolic syndrome X, okay? And it's a clustering of people that are diabetic, they're also hypertensive and obese, and they have elevated LDL cholesterol. And in these people, we tend to see a clustering of type 2 diabetes and coronary artery disease that go together, okay? That are going to tend to go together. They share a lot of the same risk factors, so they tend to occur together. And in lots of people that are type 2 diabetics, it's not the diabetes that kills them. They die from cardiovascular disease. But all of this kind of clusters together. And we think that because there are such powerful benefits of physical activity for type 2 diabetes as well as coronary artery disease, that the main thing that is driving a lot of this kind of explosion of people being type 2 diabetics is obesity and sedentary behavior. Okay, so let's talk about a little bit more about kind of the development of type 2 diabetes. Okay, so in these people that are type 2, they make insulin. At least initially, they make insulin. Okay, at least initially. So they eat something, and I guess we should talk about this probably before we do anything else. And that slide is later on, and I should just, so the normal response. How many of you have had breakfast? Who had breakfast? Okay. Some of you have, and you've put your hands up in those things. I'm trying to do this. Julia, what'd you have for breakfast? Do you mind me asking?
Granola with coconut milk and protein powder.
He sighs, right? This low glycemic index stuff that you're eating on all of this. Okay. Anybody have like Fruit Loops or like a nice kind of sugary cereal or a donut or something for breakfast? Because Julia's going to get a response, but it's not going to be nearly as fun. As anybody have anything like that? No?
I can pretend I did.
You can pretend that you did. Madison, do you like donuts?
Yeah, I love them.
Okay. So there's a Hertz donut like right, and a Dunkin' like 2 blocks from our house on 23rd Street in Oklahoma City. And every day when I drive by in the morning, it's all I can do not to just like duck in and be like, I need some donuts. My wife, every year for her birthday, we don't get birthday cake. I get a bunch of donuts and we stack the donuts up like a cake. We put candles on them and we slather it in like chocolate sauce and sprinkles and a bunch of things. So we're a big donut house at the Black household. Okay, let's imagine a scenario whereby Madison had, I don't know, like 3 donuts for breakfast or something. Okay, sounds wonderful. Within about half an hour to 45 minutes, the glucose in those donuts is going to get sort of broken down in her stomach and begin to be absorbed in her small intestine. And as that happens, then it's going to pass into her bloodstream. And so we get this progressive increase in blood glucose in a very predictable manner based upon how much glucose is in and how much simple sort of sugars and carbohydrates are in whatever food you're eating. Things like donuts that have high simple sugar content, high glycemic index, you're going to get a bigger spike faster in your blood glucose. So glucose levels in the blood begin to go up. That blood circulates around and it circulates past the pancreas. The beta cells in the pancreas sense this increase in blood glucose, and the natural response is, ooh, we've eaten something. Let's try to drive this glucose into some tissues to either use it for energy or to store it for using later, because who knows when Madison's going to get to eat again, okay? So that happens, blood glucose goes up, we get a corresponding increase in insulin, and the body is really, really good, okay? It tries to very, very tightly regulate blood glucose levels and hold it in a very constant sort of range. Your brain needs glucose to function, okay? So at all costs, the body wants to do whatever it can to maintain enough glucose for the brain to continue to function, okay? As you will see later on, if we do something and your blood glucose dips too far, the brain's response is to make you pass out and to go into a coma so that it will shut down use of glucose by other tissues as much as possible to try to maintain an adequate amount for the brain, okay? So this is really, really key. So Madison eats donuts, her blood glucose goes up, and so then we release insulin to try to bring that glucose back down to this kind of constant level. And so what happens is that over the course of, say, a couple of hours, her blood glucose goes up, the insulin goes up, and it begins then to bring the glucose down. As the glucose comes back down, then the pancreas stops releasing insulin, and they all kind of come back down together. That's a normal response, okay? We will assume that Madison is not a type 2 diabetic. She has some normal response. Let's assume that for today's purposes, I'll just pick someone else. Emma, you are under Madison on my little thing. Let's assume Emma is a type 2 diabetic. She eats the same 3 donuts, gets the same spike in blood glucose, the same initial increase in insulin. But then what happens is that Emma's muscles and other insulin sensitive tissues do not respond to that insulin correctly. So she releases the insulin, but her tissues do not want to draw glucose out of the blood. Well, that sucks. So hers, rather than leveling off and coming back down, it continues to go up, okay? It's going to continue to go up. And in response to it continuing to go up, Emma's pancreas is going to release more and more and more and more insulin. And so eventually she's going to release enough insulin that it will begin to gradually bring her glucose levels back down. But it's going to take longer, okay? And it's going to require a release of more insulin, and she's going to have a larger kind of peak increase of glucose afterwards, all right? So in that way, because she's a type 2 diabetic, her pancreas has had to work harder, and it's taken longer to get those things back down, all right? And over time, over many years of all of that, that continued elevation in glucose, okay, that's going to occur from that, because it takes longer to get back down, can have some negative consequences on a bunch of things. And the fact that her pancreas has to make more and more and more insulin, eventually she's going to wear her pancreas out. And her beta cells are going to get worn out because she's had to produce so much that she may then not be able to make any more insulin, and she basically becomes a type 1 diabetic. Okay? So development of type 2 diabetes is gradual. Okay? It's gradual. The statistics would tell us that there's probably 1 or 2 of you guys in class that have a somewhat impaired ability of your insulin to function properly in muscle and other insulin sensitive tissues. Okay, you are what we would call a pre-diabetic. Okay, and we could look, and it's probably, we would look at if there's any of you guys that are overweight or obese and are sedentary and have been so for multiple years. Y'all are probably our best guess of who is going to be the person that would be a pre-diabetic. Okay, so, but it's gradual. It appears slowly over time. And it may take years until your first symptoms develop. I mean, it may take 10 or 15 or 20 or 25 years, okay? You get to be my age, and then you may begin to see some problems. You get into your 50s and your 60s, and it really begins to kind of show up then, okay? So it's very, very gradual. We think right now about 10% of the world's population may be type 2 diabetic, okay? About 10% of the world's population. We're a little over that here in the US. And we think there's a lot of people, especially, maybe not in the US, but especially in more developing countries, that it's undiagnosed. They're type 2 diabetics and they don't realize it because there really aren't any symptoms until it gets pretty bad. By the time you begin to see symptoms, it's not that it's too late, but things have gotten to a pretty bad place. Okay? So what we have found is that this the increase in type 2 diabetes really tends to track with the increase in obesity and the increase in sedentary behavior, especially in developing countries. Also, because of all of that, the prevalence of type 2 diabetes has been constantly on the rise, pretty much everywhere, okay? One of the first things that happens when countries kind of transition from being developing countries into more sort of Western industrialized countries is everybody gets desk jobs and they stop having to do as much manual labor. And so obesity rates go up, sedentary rates go up, and then they all begin to develop type 2 diabetes. It's very, very common. As the rise of these things has gone on in places like Brazil and Argentina and China and some of the somewhat more developed African countries, South Africa, Nigeria, these places, this is exactly what happens. Okay, this is exactly what happens. Okay, so not a great situation, and it's probably, unfortunately, only going to get worse. Okay, so with type 1 diabetes, what we see with this is we're getting better at diagnosing it, but it's primarily an immune reaction. So we call that an autoimmune disorder. And you end up with what is in essence a complete insulin deficiency within a few months. Okay, so within about a year, once you've become insulin deficient, if we do not give you exogenous insulin, and this is a problem now, okay, without our ability to give you either artificial or exogenous insulin, type 1 diabetics will die. Okay, they will die. So as one might imagine then, if any of you know someone that's a type 1 diabetic, ask them how much their insulin costs, or ask them how much their insulin would cost if they didn't have insurance that would cover it, okay? It is outrageous, okay? Like a 1 month supply of insulin is $800 or $900 or something like that, okay? But if you don't have it, you die. And so, and I'm trying to remember who it is that has the patent on insulin. I think it's Eli Lilly that has the patent. But you know, they kind of have the market cornered on some of these things, and they can charge whatever they want because people have to pay it, and it's becoming a real issue. Okay. So typically, when you develop and become a type 1 diabetic, it happens really, really quickly. Usually your symptoms are going to begin to appear within just a few weeks of the immune system beginning to attack your beta cells. So things go downhill really, really quickly. And we'll talk a little bit about what some of those kind of hallmark symptoms are in the coming slides. But only about 1% of the world's population is a type 1 diabetic. So it's roughly about 10% of all diabetes cases. So if we look at these kinds of things, right, if about 10 or 11% of the world's population in total has diabetes, then only about 1 in 10 of people that are diabetic are type 1. So this is definitely the least prevalent of the two. Okay. But much like type 2, rates are increasing. Okay, rates are increasing, and we don't really understand why. Why are we in situations where we're getting more and more of this autoimmune type 1 diabetes? Is this simply a fact that we're better, like we are with cancer, that we're better able to diagnose these things? And it's kind of always been this way, and we've just been underestimating because we've not tracked it very well, or is there something new that's going on that's making these rates kind of go up? Okay. So what you guys can see here is a little man named Ted Ryder. And so here we have a picture of Ted in 1922 I don't really know if that's like his Boy Scout uniform or kind of what all is going on with this. He's like a Canadian little kind of young military outfit that he has here. But here's Ted, 1922. Here's our same man about a year later in 1923. And you guys will notice that he looks a little gaunt and maybe undernourished here, has a much more kind of normal kind of adolescent look to him in this one, okay? And so Ted was one of the first humans to be treated with exogenous insulin. He was a type 1 diabetic, and so he had onset of diabetes when he was very little. He's probably 5 or 6 here or something like that, and was one of the first to get insulin. And then because of that, he was able to live until he was about 76 years old, okay? And so what you can see over here is the guys that discovered that if we gave people insulin, we could, in essence, use that as a way to treat their type 1 diabetes. This is, and I don't know their first names, unfortunately. This is the scientists, their last names were Banting and Best. And they were able to extract insulin from the pancreas of a dog and give it here to their diabetic dog, Marjorie, who is right here. And they were able to use insulin from one dog to treat type 1 diabetes in another dog. Okay, so we see diabetes, both type 1 and type 2 in dogs and cats. Some of our friends have a giant diabetic cat. They have to give him insulin injections twice a day, and he is really fussy about all of that. But what are you going to do in those ways? And so they were basically able to take exogenous insulin from a dog. I swear that the original insulin that they were giving people was from dogs. And it still manages to work in these particular ways. Okay. So we've only been able to kind of treat and know how to treat type 1 diabetes really well for about 100 years. Okay. So those are good things for us to know. Okay. So why do we care? I mean, it makes some sense, right, that if we don't treat your type 1 diabetes with insulin, you're just going to die, okay? But what about type 2 diabetes? What about people that like, this can work, but it doesn't work very well? Or I'm not controlling my type 1 diabetes as well as I can. So the big problem with diabetes is related to its hallmark symptom, which is hyperglycemia. So you've got these chronically elevated levels of glucose in your blood. And what we know that happens from this is that chronically high levels of glucose are going to lead to elevations in blood pressure. And the combination of those two things can lead to damage to blood vessels and nerves. Okay? That's the wrong way. Leads to damage to blood vessels and nerves, especially, blood vessels and nerves, especially in the small nerves that are going to be in your eyes and your small sensory nerves in your feet and your hands and those kinds of things. okay, as well as the nerves and the blood vessels that are going to go to your kidneys. And so the big complications from diabetes are cardiovascular disease, especially coronary artery disease and stroke, because of your high blood pressure, and it's typically associated with obesity. So we see those kinds of things, but then we see kidney disease. Having to filter all of this glucose out is going to raise blood pressure across the nephron and can cause damage in the nephrons in your kidneys. Let me just tell you guys, kidney disease is a terrible thing. You have to go on dialysis and all of that stuff with your kidneys and liver. When those things go bad, it's really, really nasty and really messy. We don't want that. But then, additionally, diabetes or uncontrolled diabetes is one of the leading causes of adult onset blindness, okay, because of damage to the blood vessels that deprive the nerve endings in your eyes of blood. And so the nerve endings will die, so you go blind. You also can get nerve damage or neuropathies out, especially in your hands and your feet. And that can then also, because of lack of blood flow to those nerves and lack of blood flow to those tissues, you can get necrosis in your tissues, and we have to have amputations. Uncontrolled diabetes is also the leading sort of cause of like foot or lower leg amputations in adults as well. Okay. So do any of you guys know anybody that has maybe a diabetic neuropathy that's had type 2 diabetes for a while and they've had nerve damage because of all of that?
My grandfather had some issues with his feet. He had also issues going on because he was a type 2 diabetic and also was on dialysis with kidney disease and all that fun jazz. But he did have some issues with his feet. He didn't have to have them amputated, though.
Did he ever talk about like how painful that was, Emma?
Not really. He was kind of a stoic kind of guy, so
Sure.
he at least didn't talk about it with me, but I know that he had some issues because my aunt would take care of him.
Sure. So a lot of you guys, if you want to be an occupational therapist, you do stuff where you're going to see inpatient people in the hospital. You're going to have to contend with a lot of older adults that are probably type 2 diabetics that may have like open wounds on their feet and lower leg that won't heal because they have such poor blood flow in those areas and they have associated nerve damage. It has been described to me, and I'm hopeful that I never have to experience this, that we could argue that like having diabetic neuropathies are one of the single most painful things that can happen to anybody. That because you get damage to these afferent nociceptors, they fire indiscriminately and you can't get them to shut off. Like there's no external stimulus, they just fire. And the pain is described as being like shooting and sharp and especially burning, like uncontrollably in some ways. This is not stuff that like aspirin and Advil can knock back. Okay, this is stuff that you need the really powerful pain medications. You need Oxycontin, you need opioid drugs to make any kind of inroads on all of this. And even then, we don't have particularly good treatments. For a lot of nerve related pain, like if you have low back pain, kind of nerve irritation, they give people something called gabapentin, which kind of mimics a neurotransmitter. We can see some effects from all of that or some mixture from those two kinds of things, but there's basically nothing that we can do for once you kind of develop these neuropathies. And so this is one of the reasons that we've got to try as best we can to get early diagnosis and early treatment for this. Because if it's left uncontrolled, then we're going to be in some really, really bad places with all of this. Okay. So being and having a chronic sort of type 2 diabetic whose symptoms have been uncontrolled for a while, they're going to end up in a bad place. Like you're going to have cardiovascular disease, but they're going to have kidney damage and liver damage and potentially blindness and peripheral tissue damage and stuff that's going to hurt and cause amputations. It's really, really, really a nasty kind of thing, kind of by the end in people that don't have it well controlled. Okay, so hopefully we can use some of that to scare people into doing better. So how do we treat diabetes? Well, it's going to depend upon not only the type of diabetes, but also the severity of your symptoms and kind of how far it's progressed. For type 1 diabetes, the main and primary thing is going to be medication. Okay, we really have to just give you insulin, and that should solve most of your problems. If you're a type 2 diabetic, then we want to try some combination potentially of increasing physical activity altering your diet, and then if we need to, adding some medications on top of all of that. And we'll talk about the medications and how those things work here, okay? So we can give you what we call oral anti-hyperglycemic agents. We can give you something, we can give you a drug that will hopefully try to mimic the functions of insulin and drive glucose out of your blood and into your tissues, okay? We can also kind of give you drugs that will hopefully induce additional insulin secretion that are going to work those ways. But the primary one that we give is something that's called an insulin sensitizer, okay? An insulin sensitizer. And the most commonly prescribed one of these is something called metformin, okay? Called metformin. Much like we talked about with cardiovascular disease, that we give people lipid-lowering drugs. If you look at the most widely prescribed drugs in the world, it's a couple of things that lower LDL cholesterol. It's metformin, and then it's drugs for erectile dysfunction are the ones that are going to be the kind of most commonly prescribed things. So that tells you a little bit about kind of what all is going on in the world. But what metformin does is it makes your insulin receptors work better. And so you make your receptors work better, and you release your insulin as your glucose goes up, and you're going to get more glucose uptake from any amount of insulin that's being released. So the insulin sensitizers make you function much more so like a normal person in that way. And there can be some things that are going to be digestion modulators that are going to inhibit glucose absorption in the gut. And so if you get people that are overeating, you can give them stuff like this, and it prevents absorption of some of the glucose. And so that prevents quite as steep of a rise in their blood glucose and those kinds of things. But mostly we want to do things with these insulin sensitizers. Okay? There's some fascinating evidence on certain kinds of, we'll call them supplements. One of them, cinnamon. It seems like if people eat or consume or supplement with cinnamon, that cinnamon may actually function in some ways as an insulin sensitizer. It's not nearly as effective as, say, metformin and some other drugs that do this, but you may get a little bit of stuff out of that, which I find to be pretty crazy. So if you're a type 1 diabetic, then basically what we give you is insulin, and you can do an injection of insulin, or depending upon kind of how you want to run things, like Dr. Pinku, he has a pump. And so he has a pump, and the pump is going to be sort of, it sticks in and it's connected to a blood glucose analyzer, and like every half an hour or something, it takes a little blood sample and it looks at how much it looks at how much glucose is in there, and then it pumps and releases insulin in, and kind of to try to exactly match the rise in blood glucose level. Otherwise, you got to stick your finger yourself, and then you got to dose out some insulin and give yourself an injection. Okay. Most insurance companies now having these pumps, that's standard of care, and so the insurance companies will pay for these things, but you do have to sort of go around with the pump and the way to monitor your blood glucose, both sort of stuck into you in those ways. And Dr. Pinku says that it is really not painful, and you just kind of get used to it over time. And so I suppose the alternative is in some ways even more cumbersome. Wyatt, you had a question.
Yeah, I was just so don't the pumps like depend also on your body fat? Because I know my friend who's type 1 diabetic, he couldn't get a pump. Oh, he still can't get a pump just because he doesn't have enough body fat to be able to have a pump. Because I think there's like a certain like either weight or
Really?
I'm not sure what the specifics are. Because he's been trying to get a pump for. I mean, he was diagnosed in 8th grade, and he's been trying to get enough weight to get a pump ever since then. He's still not able to get one because he doesn't have enough body fat, I guess.
That's fascinating. I'm not familiar with that, but I wonder if they need to you need the subcutaneous body fat, because it actually injects it into the fat rather than all the way down into the other tissue, and then it kind of diffuses from there. I'm typing. I'll try to text Dr. Pinku and see if he knows anything about that. So that's really interesting. So, okay. Other questions? No? Okay. All right. know if you have hyperglycemia. We were to take a blood sample from you. We want to look at your kind of at your blood glucose levels. So typically, a level that is kind of chronically above 250 milligrams per deciliter is we're gonna call that to be an elevated level. Okay. I know that we talked about that if you're over 200 but under like 230, then you're a pre-diabetic and you have elevated fasting glucose. This is typically going to be, this doesn't have to be fasting glucose levels, but we can just look at it this way. That's going to be indicative. We can also do a thing and see how much insulin you release. We can give you a glucose challenge and then take a blood sample and look for insulin in your blood. And you may be in a place where you don't get enough, you don't release enough of all of these things. But we can look at polyuria, right? You're producing more urine. You're going to have increased glucose in your urine. Other symptoms are like changes in your vision, changes in your mood, fatigue and weakness. And then another hallmark one, which a lot of people get, it's like people are ketogenic. It's like they're on the keto diet, okay? They cannot bring carbohydrates into their muscles. So what they have to do is to convert some of those carbohydrates or convert protein or fat into ketone bodies in their liver. And then they will metabolize those ketone bodies, but they're going to breathe some of that stuff off. And so they have acetone or this kind of sweet smelling breath in that way. Oftentimes people that are type 1 diabetics are going to be skinny. They're going to lose weight kind of suddenly when they're doing all of that and have a hard time putting it back on because they can't drive glucose into some tissues and those things. Okay? That acetone breath, as I said, is from catabolism. A lot of times they're breaking down protein, and if they're not eating enough protein, they're going to break down protein from muscle tissue. They go into ketosis or ketoacidosis. And eventually, if your blood glucose is too high for too long and things, you can go into what's called a diabetic coma. Okay, you can go into a diabetic coma. Hypoglycemia, which is going to potentially be a problem for people that don't get their insulin doses correct. This is the big issue with exercise in people that are type 1 diabetics. As you guys will see, the thing that exercise does that's really useful is exercise functions just like insulin. So muscle contractions drive glucose from your blood into muscle specifically, okay? Muscle contractions also make your insulin receptors more sensitive to insulin. And so it's very useful for us to have people undertake exercise if they're a type 2 diabetic because it actually functions to drive the glucose in and it helps with their symptoms. If you're a type 1 diabetic though, what you have to be very, very careful of is I've taken a dose of insulin because I ate something and now I'm going to go and exercise and I'm basically going to get a double whammy effect. The insulin's going to drive glucose in, and then additionally the exercise is going to drive glucose in. And so my blood glucose levels may get to be too low. And if I do that, then I become hypoglycemic, okay, or I've overdosed my insulin, and you get some of the same things: weakness, confusion, people become unresponsive, and they may lose consciousness and kind of come in and out of consciousness. When people become hypoglycemic, they need to eat something. So I had a student in class a couple of years ago. She was a type 1 diabetic, and she readily admitted that she did not do a good job of monitoring her glucose levels. And so, like, she told me on the first day of class, like, I should always have some orange juice and a candy bar or something in my backpack, but there may be days that, like, I'm awake, but I'm not really here. And if that's the case, like, if you see that, like, you've got to give me to drink my orange juice and all of those things, or there's always a chance that I might, like, pass out in class. And if that happens, like, dump the orange juice, like, you know, down my throat in those ways. And so, weirdly enough, she's a nurse now. And so it was always dicey because we had class at 8 o'clock in the morning, and sometimes she wouldn't eat breakfast and things. And overnight, you know, her glucose levels would fall a little bit too much. And so despite my protestations, I would usually ask her every day, like, you know, Michaela, did you have breakfast? Did you have breakfast today? And if not, like, okay, drink your orange juice. Or we would run over and get a candy bar out of the machine for her. So anyway, things that you guys may in some ways encounter. Okay, so we'll go for just about 5 more minutes, and then we will, and we'll take a little break. So I told you guys previously that glucose metabolism, and by metabolism, what we really mean is you eat something, your blood glucose levels go up, and then the body strives very much to then get those blood glucose levels back down and keep them at some solid level. Additionally, when you're in between meals, okay, you haven't eaten anything, your blood glucose levels are going to begin to fall a little bit. And the body's natural response then is to do some things to try to increase your blood glucose levels. Okay, that's going to be the other piece of this. And so if insulin is our hormone that decreases blood glucose, okay, then on the other side of things, there are what we call counter-regulatory hormones: glucagon, epinephrine, norepinephrine, growth hormone, and cortisol. We could also group testosterone in there. They're going to function to try to increase blood glucose levels. Okay, so if you're in between meals, what will happen is glucagon will go up, epi and norepi will go up, cortisol will go up, and they will lead to a breakdown of stored glucose in the glycogen in your liver and the glycogen in your skeletal muscle to try to raise blood glucose levels back up. Okay, this is really all I want you guys to know about counter-regulatory hormones. Okay, I know it's on the study guide. You all will get into kind of the hows and the whys of all of this a little bit more so, and how exercise alters all of this in exercise physiology class. It's a really, really, really important process. But I just want you all to know that we're going to focus mostly on insulin on this side of things, okay? But there are some other things that can go on to try to raise blood glucose levels as well, okay? So we know that insulin is an anabolic hormone, okay? It comes from the beta cells in the pancreas, and it's generally going to be secreted in response to increases in blood glucose levels. It also tends to be released in response sometimes after exercise, because as you guys will learn in exercise phys, one of the things that exercise does is when you exercise, you get a big glucagon, epinephrine, and norepinephrine response. And so it releases a lot of stored glucose into your blood while you're exercising. And then that can lead to a corresponding increase in insulin. So it has some anabolic effects on skeletal muscle and those kinds of things. That's also why they encourage you, because you want the insulin response. When you take post-workout protein, they oftentimes now will encourage you to drink it with some carbohydrate, because you're going to then get an increase in insulin that will help drive some of those amino acids into your skeletal muscle. Okay? Hence the use of chocolate milk as a post-workout supplement in some ways. It's like the exact right formulation of the amount of carbs to the amount of fat and protein that we want in things that are going to go on afterwards. Okay, but that's what insulin does. Okay, and so multiple tissues are going to have receptors for insulin, and they're all going to have slightly different functions. But the big one is mostly going to be that it's going to drive glucose and other substrates into those tissues so that we can either use them for energy or store them, and it functions to inhibit substrate breakdown. So it's going to inhibit catabolism. So when insulin binds to its receptors on skeletal muscle, that's going to inhibit the breakdown of protein in those muscles. So it's going to in some ways function to limit muscle wasting. So in skeletal muscle, when insulin binds, you get the translocation of a glucose receptor called GLUT4 that we'll talk a lot more about in the next couple of slides. It moves GLUT4 to the muscle membrane. That leads to an increase in glucose uptake. It also, in skeletal muscle, drives taking these glucose molecules that are getting brought in and hooking them together to make glycogen in your muscle. So it drives glycogen synthesis. So you can store some glucose in skeletal muscle for when you might need it during exercise later on. Okay. In adipose tissue, insulin's going to drive glucose going into adipose tissue. It's going to drive the synthesis then of turning this glucose into triglycerides. It's going to drive all of that, and it's going to inhibit the breakdown of adipose tissue. Okay, so That's one of the reasons why we think that if we can not get a lot of insulin response when you're on the keto diet and things, it's going to prevent it's going to counteract this blunting of lipolysis, and you may then therefore break down more tissue. In the liver, you're going to get a lot of the similar things, but it's not going to signal through GLUT4. It's going to signal through GLUT2, okay? And it's going to increase glucose uptake into the liver. It's going to increase synthesis of glycogen in the liver. You mainly store glycogen in your body in the liver and in skeletal muscle. Y'all will talk a whole bunch about that in Exercise Phys, about why the skeletal muscle glycogen stores are used in some instances and why liver ones are used in others. And it's going to also, insulin blunts what we call hepatic glucose production. It blunts the liver taking non-glucose substrates, proteins, fat, and things, and doing something called gluconeogenesis. And basically, the liver will make glucose out of non-glucose or non-carbohydrate substances, and it blunts a lot of that kind of stuff. Okay? And then overall, systemically, it lowers blood glucose levels, and it seems to drive protein synthesis and drive growth. Okay? And drive growth. Okay. That's as good a place as any for us to take a little break. So I'm going to stop sharing. We're back recording. Back to sharing the screen. Okay. So in the next slide, and I am hopeful that you guys have seen this before, like maybe in physiology class or something. I'm hopeful that that's happened. But this is the basic sort of signaling cascade that happens, okay, when we're going to get insulin binding to its receptor, and the tissue that we're going to look at as our kind of target tissue in this one is going to be skeletal muscle. Okay, so in our picture, and again, I apologize, I probably should do a better job of trying to draw this out in these things, but out here, this is a capillary. Okay, this is a capillary. So we've got glucose in a capillary. All right, down here we have, this is a skeletal muscle fiber. So you've got a capillary in close contact with a muscle fiber. We've got glucose floating around in the capillary because you've ate something, say maybe half an hour ago. On the surface of our muscle fibers, here on the sarcolemma, all of them have these. There's a receptor for insulin, okay? And there's many, many, many of these kind of all along the length of the fiber, but I'm just going to use one here to represent this, okay? Also, inside of your skeletal muscle fiber, you are going to have, these are little vesicles, okay? So little storage sites, and in those vesicles are going to be a glucose transporter that is called GLUT4, or glucose transporter number 4, okay? Now there is a GLUT1 and a GLUT2 and a GLUT3 and like a GLUT6 and all of these things, but in skeletal muscle, the primary one that we're concerned about for insulin signaling is GLUT4, okay? So when you've not eaten for a little while, you have all these vesicles, the GLUT4 is just kind of hanging out in the vesicles inside your skeletal muscle, okay? I ate something, I've got glucose in these capillaries. That glucose at the pancreas stimulates the beta cells to release insulin. So insulin gets released, here it comes, right? I now have insulin in my capillary. That insulin floats by, it sees its receptor, and it binds to its receptor, okay? So once we have bound the receptor, there's going to be a complex interaction of things that are going to occur, and it's called a signaling cascade. But through a series of steps, binding on this insulin receptor is going to send a signal from the receptor down into the skeletal muscle fiber that's going to direct these vesicles to move themselves up to the cell membrane. And the vesicle has a lipid bilayer just like the cell membrane. It gets up there and then it just sort of pushes itself into the membrane. And so now we have these GLUT4 glucose transporters that are going to be in the membrane of that skeletal muscle fiber. Once that happens, then the glucose floats by, it interacts with these GLUT4, and it brings the glucose from out here in the capillary, and it pulls it into the skeletal muscle fiber, okay? It pulls it into the skeletal muscle fiber. Okay. And then once it's in here, then we'll either use this glucose in glycolysis or through glycolysis and then into the Krebs cycle for energy, or it may get stored and turned into glycogen. Okay? But this is the general way that this pathway works. So imagine I'm a type 1 diabetic and I get glucose, but my pancreas doesn't make any insulin, so there's no stimulation here on the receptor, so there's no signal to put GLUT4 into the membrane. So I don't lower my blood glucose in that way. Okay? Imagine I'm a type 2 diabetic though, and I make insulin and it binds to its receptor, and rather than bringing 3 vesicles up to put GLUT4 in, it only brings up 1 vesicle. Okay? And so I'm not going to bring as much glucose in per every molecule of insulin that binds to its receptor as a normal healthy person would. Okay? Does that as a general idea make sense to you guys? Okay. All right. So the next slide, and you guys don't have to know all of this, but this is the skeletal muscle membrane. Here's the insulin receptor, and I want you to note all of these different things, okay, that are going to be in some way kind of controlled and integrated through this insulin response that's going to be all the way kind of down here that may get us over here to get these GLUT4 vesicles to go into the muscle membrane. So there's many, many, many steps. And then there's some other, you will note, like, so the big thing is it signals through something called ERS1, and then they're going to phosphorylate some things here, and then this will eventually tell GLUT4 to do things. But there's also some interactions. We said insulin is anabolic. Insulin works through mTOR and the AKT signaling pathway. mTOR, this is the primary thing that drives protein synthesis, that drives muscle growth, and so it has some interactions, both inhibitory and excitatory with all of that, as well as some other things. So lots of steps that go on here and lots of places where things could go wrong. Okay, you don't have to know this. I just want you to get an appreciation that this is a pretty complex interaction that's going to happen. Okay, so let's imagine I'm a type 1 diabetic and I don't make any insulin. Can I get some glucose into my tissues? The answer is yes. GLUT1 will have continuous low levels of uptake. You always have GLUT1 in your skeletal muscle membrane, so you'll get some in that way. Okay. You're also going to get some through what we would call contraction-mediated GLUT4 translocation. Okay, so let me back up. If this is the signaling pathway, this is what's normally driven by insulin. Okay, no insulin, but I start doing bicep curls. Okay, the contraction in my bicep somehow hijacks the signaling cascade, and it says, okay, we don't have any insulin, but it activates something downstream of the insulin receptor that tells the GLUT4 to go to the muscle membrane. And when it does that, you're going to get glucose uptake into that actively contracting bit of skeletal muscle. Okay? And so that is called contraction-mediated glucose uptake. It is other times called the insulin-like effect of exercise or the insulin-like effect of muscle contractions. Okay? So weirdly, and you guys will learn about this more in Dr. Mike's class, but weirdly, when you start exercising, insulin levels drop off completely. We almost completely shut down insulin production when you begin exercising, okay? Whereas your counter-regulatory hormones are all going to go up. And so the primary way that we get glucose into contracting skeletal muscle during a bout of exercise is through this contraction-mediated system, not through insulin, okay? And there's some complicated reasons behind all of that, but the big issue is just that if you're getting contraction-mediated uptake and insulin driven uptake, then your blood glucose may fall too far and you could become hypoglycemic, and that could be really, really bad. Okay, but exercise does this. So you have a type 2 diabetic who has a hard time driving glucose into their muscle, have them exercise, and it drives it in there. Okay, so we've talked about those kinds of things. I really don't want you guys to do and know any more about these counter-regulatory hormones than just sort of what they are, and that their primary function is to mobilize like substrates. So it's to put free fatty acids, triglycerides, and carbohydrate in the form of glucose or something that's been stored into the bloodstream. And that's really all that I want you to know, okay? So don't worry about kind of this bottom end of these other kinds of things. These graphs just roughly show you what I just said, okay? Here's a graph that we're doing 3 hours of exercise. So this is a person riding a bike for 3 hours. And you will note here in blue is their glucose response, right? That their glucose goes up a little bit and it stays pretty constant during that bout of exercise, whereas their insulin levels are going to dramatically fall over time, okay? This graph is basically the same 180 minutes, but we've got blood glucose in blue, you've got insulin in orange, but then you have epinephrine, norepinephrine, and glucagon. Oh, sorry, that's cortisol. That's not insulin. So there's no insulin in this one. My apologies. But you will note that your counter-regulatory hormones are going to go up over time, and your glucose is staying pretty constant. So these counter-regulatory hormones are driving glucose out of storage and into your bloodstream so you can use it during exercise. So we can hold it pretty constant. Okay? So this part of stuff I don't really want you guys to worry about, okay? The question, why is it important to prevent a decline in blood glucose, is because you will die, okay? You will die. And then there are different ways to get at this in type 1 and type 2 folks that are diabetic, but this is the big take home. If your blood glucose falls too far, you will go into a coma and you will eventually die. So we need to be very, very careful about kind of how all of that stuff gets moved around, okay? So don't worry about this. Is the exercise response in a type 1 diabetic. They actually during exercise look a lot like regular people. We just want to make sure they don't get insulin beforehand in the midst of all of these, okay? So as we talked about, exercise has this insulin-like effect, okay? We do muscle contractions, you get your signal, right? This is just kind of graphically showing you guys what happens in the midst of those and why a type 1 diabetic can easily take glucose up during exercise, even though they don't have any insulin, okay? The second thing that happens that we really know, and this is going to be the one, this is the piece that I want you guys to appreciate, because this is the thing that lets us use exercise as a potential treatment or a preventative measure for people that are type 2 diabetics, okay? Exercise increases insulin sensitivity, okay? Exercise makes your insulin receptors more sensitive to insulin, and it makes that downstream signaling process that leads to GLUT4 translocation more efficient, okay? So the capacity of cells to increase glucose uptake in response to a given insulin stimulation, that is this idea of sensitivity, okay? If we look at you in the hours to a couple of days after a bout of exercise, it can be walking, it can be running, it can be cycling, it can be resistance training. It really doesn't matter. Just contract your muscles. Is that insulin stimulated glucose uptake and the synthesis of glycogen are going to increase in, within a couple of hours after a bout of exercise, and it's going to stay elevated for a couple of days, okay? For a couple of days afterwards. Uptake is going to increase in the absence of insulin for about an hour, so you're going to drive more in through GLUT1 and some other mechanisms after exercise, but this is the really, really kind of key thing, okay, is that after about 2 hours, uptake from insulin goes way up, and it may last for up to 72 hours. So you go exercise today, and you may have better insulin sensitivity for up to 3 days from now, okay? You're a type 2 diabetic and you have poor insulin sensitivity, go for a walk today, and within 2 hours, your insulin sensitivity is getting closer to that of a normal person. And it's going to stay that way for a couple of days. And so then a couple of days from now, you go exercise again, right? And then you get another 72 hours of improved function. And you wait a couple of days and you go again. And so you can see potentially a scenario whereby I'm a type 2 diabetic and I have poor insulin sensitivity, but as long as I am relatively consistent and I go exercise every couple of days, I can actually try to rescue some of this insulin sensitivity that I have lost by being a type 2 diabetic. So that's one of the reasons why, one, people that are very, very active have a hard time ever becoming a type 2 diabetic because they're always kind of driving and stimulating this extra insulin sensitivity, okay? And once you've become a type 2 diabetic, we can use physical activity and exercise as a very useful and powerful treatment because of all of this, okay? And a lot of this is primarily due to an increase in GLUT4 protein levels. So what seems to happen is that in the hours after exercise for several days, your muscle cells will synthesize and make more GLUT4 protein. So there's more GLUT4 vesicles with GLUT4 in them. And so every time insulin binds, it's going to shoot more of those out to the membrane to be able to bring things in. Okay. All right, so we've really kind of reached a lot of the end kind of portion of stuff that I think I want you guys to know about all of this, okay? A lot of what is left in the slides is going to be some research findings, just kind of justifying the stuff that we've talked about. So here's exercise as a therapy. You will note that in this, they're giving people some kind of lifestyle intervention, which is exercise, or they're giving people metformin, right? And so we're looking basically at change in physical activity, changes in weight, and those kinds of things. What we know from a lot of this is that hemoglobin AC1 levels are gonna kind of stay down in the midst of some of these kinds of things. Okay, so I've kind of summed up all of this. There's lots of benefits to type 2 diabetes. You get improved glucose uptake, improved insulin sensitivity, reduction in cardiovascular risk factors, right? So there's this really, really, really key kind of thing with physical activity and obesity in being ways to prevent and treat type 2 diabetes, okay? So what if we know that it's good for them, then how should we ask them to exercise, or what should we have them do, okay? Realistically, unless they have some other sort of pathology, there's no real major limitations or things to worry about with exercising a type 2 diabetic person, okay? We do a complete health screening. If they are a type 2 diabetic, they're going to be considered high risk. They need to go to a physician, okay? Then we need to get them checked out. But one of the things that we know is that if they can lose a little bit of weight, that seems to improve glucose control. There's something kind of magic about expending about 2,000 kcals of calories per week. And so you can work this out. They need to do the equivalent of about 20 miles worth of walking over the course of a week. Right, so can you go like 3 miles a day or something? Could you do a half an hour, 45 minutes or thereabouts every day? That seems to really be of some benefit to them. So if you look at the American Diabetic Association, their recommendation for physical activity looks a whole lot just like the recommendations for normal people. 150 minutes per week of moderate aerobic activity, right? No more than 2 consecutive days without activity. This is to help us maintain that increase in sensitivity that we're going to get post our bout. They recommend a couple of sessions of resistance training. One of the things that we know that's really beneficial for people that are type 2 diabetics is if we can increase their muscle mass, that really seems to be a very, very beneficial thing for their insulin sensitivity. That was the primary thing that we were driving at when I was doing my PhD in people that had spinal cord injuries. They developed type 2 diabetes at like 5 or 6 times the rate of the regular population. And they have very, very little muscle mass. And so what we could find was that as we made their muscle mass go up, there were more places for insulin to bind, or more places for their glucose to go, and it really seemed to have these very powerful and profound effects on their insulin sensitivity and their ability to kind of lower their blood glucose. Okay. We want to decrease sedentary behavior. We want to interrupt sitting every 30 minutes if we can. They talk about flexibility and balance for older adults with diabetes. You guys know that may just help keep range of motion and keep balance. We know that flexibility is not going to magically make them not be sort of a type 2 diabetic, okay? Pretty straightforward stuff here. The intensities, you can see the heart rate ranges and kind of the fit types of things. What about a type 1 diabetic? Stuff's a little different in type 1 diabetes. We know that it's good for them, okay? We know that it's good for them, but we have to pay attention to what's happening in people that are type 1 diabetics. There's no real limitations, okay? Their muscles should work like normal. And we're going to check them for cardiovascular disease risk and those kinds of things. But the thing that we've got to be very, very careful about is this last point on this slide, okay? If they have not eaten a sufficient amount of glucose beforehand, and or they've had a recent dose of insulin that would drive their blood glucose down, we've got to be very, very cognizant of that if we're about to have them go and exercise. Because what we don't want to happen is I ate something, I took an insulin dose to match roughly what I ate, and then from there I went and I ran for an hour, and that drove even more glucose out of my blood and into my muscles, and now I've become hypoglycemic. So we just have to be really, really careful. All of the things they're going to recommend is that if they're exercising, that maybe you do it with a partner. If you're exercising, make sure that you eat immediately beforehand. If you're exercising, have some Gatorade or a candy bar or something on hand. And as soon as you finish, to try to make sure that you're sort of ingesting a sufficient amount of glucose. We really, really, really are worried about kind of hypoglycemia being an issue. Recommendations in them, pretty straightforward, no real need for us to kind of talk about those kinds of things. Yep, must have glucose products when we're exercising. You need glucose tablets or something like that. And then like if we were going to do it in class on those kinds of things, I'm always like, hey, let your instructor know you're diabetic so that we can do those things. And they obviously recommend having a buddy. Okay, so there's a few more slides. I don't really care. This stuff is not really that. Don't worry about this. This is just talking about like, what about doing anaerobic exercise? Is it safe to do like sprinting exercise and resistance training in people that are diabetic? And the answer, of course, is yes, it's perfectly fine. Here's some stuff doing sprint trials in type 1 diabetics. Don't worry about this. This is just a lot of Dr. Pinku's stuff that he thinks is really cool. The big take home is just, it's fine. It can be done. The same kind of considerations that we're going to see. Sprinting exercise seems to also have similar benefits to kind of longer term sort of stuff. Summary, take home. Okay, there we go. So don't really worry about that last kind of stuff after our considerations of exercise in type 1 diabetics. Okay. Stop share. Are there any questions about this group? No? Chandler.
Okay, so the slide showed us. Oh, hang on, break it. Shh. But does neuroglycopenia, can it be like caused by people on a ketogenic diet since it's low carbs?
You would ask that, wouldn't you? I'm not 100% sure, Chandler. I would need to go and try to look that up. I guess there's a chance that it could, but I don't know. I'm not even going to try to wildly speculate. I'm just going to say I'm not sure. My guess is that it probably doesn't do it too much, or we'd know about it a lot more. We'd hear about it a lot more. There's enough venom, we'll just say, on both sides of the low carb, regular carb sort of diet debate. I mean, there are people that think that the low carb diet, it has some very profound effects on type 2 diabetics. It can be very useful for them. It in some people can be very useful to help maintain a caloric deficit or those things and help with weight loss and those types of things. But I don't know. Sorry.
That's okay.
Are you a low carb person? I try to be very, down the middle in my opinions of those things.
No, I'm not. I was just curious.
Just curious. Okay. There's some very outspoken low carb people that are out there. If you're on Twitter with like the low carb community is very aggressive in, there's a couple of guys that work for the National Institute of Health and are some big kind of obesity researchers, and they don't like the fact that they don't just make everybody do low carb, because they have some data where they've tried to do controlled studies, and they find that if you control for the total number of calories that people are ingesting, that in general, the calories ingested are a better predictor of like weight loss and glucose control and things than the specific content of those calories, kind of macromolecule content, and they have a hard time with that. So anyway, we'll just leave it there. I won't wade in, because I'm not an expert in any of that kind of stuff. All right. Well, if there are no other questions, then I will let you guys get out of here, okay? So remember, test tomorrow, 10:30. You'll have 4 hours. We will also not have class. I see you, John. We will not have class, okay? It will not be lecture at 10:30 tomorrow. I will be driving in a car, I'm afraid, and that can get real dicey because I know for certain if I'm talking on the phone, Ellis thinks that if we Zoom or we FaceTime that we're talking to Grandma and Grandpa and she wants to be a part of it. And while that can be fun for a little while, it's not really conducive. So I'm going to post a lecture for tomorrow on physical activity, exercise, and cancer. And I'm just going to post the one from last summer that I did. I was looking at the one that I did from the fall and the spring, and I'm in the classroom over in Collins, and there are times it's a little bit difficult to kind of hear everything. And so I think the one from last summer is going to have the cleanest audio. So I'm just going to post that, okay? As of right now, we will have class. There will be synchronous lecture on Monday. I think that won't be a problem. If something changes, I will let you know. But we're going back to Arkansas. But I think by Monday we should be at my parents' where I know the internet is sufficient, and hopefully we won't have that same problem that we had last time. Okay. All right. John and then Emma.
Mine was answered, so never mind.
Okay, Emma.
I thought Monday was a holiday and that classes weren't canceled, or that they were canceled. I don't know why I can't talk. Like as an observance of 4th of July.
I don't know the answer to that. I will look into that and let you know.
Okay.
I will check. And if it is, then that's fine. I'll just post 2 lectures or something, and we'll try to get ourselves caught up on Tuesday. But I'll check and let you guys know. Sunny.
I had emailed you about my testing scheduling, so just a heads up.
I have seen that I have an email, and so
Perfect.
I'll get in touch and we'll figure out when we need to do it. Okay.
Thank
So,
you.
Anybody else, if you've got a scheduling issue with the test tomorrow, let me know and we'll get it all set up. Okay. And if you guys have questions during the test, I'll be in the car. Call me, text me, or something, and we'll try to get you fixed up and squared away. Okay. All right. That is all of it.